released On the Path to Better Health. It's a report that examines BC trends in chronic disease over the past decade and outlines future opportunities for prevention. This webinar will include highlights from the report, and our expert speakers will provide a closer look at some promising paths to prevention. I'll tell you more about the program we have lined up for you shortly, but before we get rolling, I have a few housekeeping items I'd just like to review with you. First of all, if you're having trouble hearing myself or our speakers, try turning up the volume on your phone or your computer. And of course, we really want your input today, so we'll be asking you to use the control panel on the right-hand corner of your screen. You can have a look at that. There you can type in your questions for our speakers as you think of them, because we'll be having a question period after each speaker and a final round at the end of all three presentations. We'd also like you to participate in some polls. We'll give you a heads up that the poll is coming, and you'll see a blue screen that has multiple choice questions. Please respond to the polls. You'll have a few seconds to do so, and then we'll publish the results so that everyone can see. And the polls certainly provide our panelists and you with instant feedback. And again, we really want to hear your questions and comments, and you can submit them at any time, either during the presentations or following them, by simply typing them in the question box on the right-hand side of the screen. And please indicate if there's someone that you're addressing their question to. We'll certainly answer as many questions as we have time for, and if we miss any of them, we'll send out a post-event email with missed questions and answers. And I'd also like to tell you that all of the presentations will be on our website in the next, it'll take a few days to get them up, but on our website, which is www.bchealthyliving.ca. So first of all, let me tell you about our program. To start off, I'm going to provide an overview of some of the findings from BCHLA's On the Path to Better Health report. The report itself provides a snapshot of chronic diseases in British Columbia in recent years. It discusses some of the contributing risk factors and health inequities, and it explores a range of approaches, policies, and actions that could reduce chronic disease in the decade ahead. Following this overview, we're pleased to have presentation from experts who can speak to the potential of 3 specific routes for improving health over the next 10 years. Our first guest speaker, Stephen Smith, will discuss the connection between mental and physical wellness and look at how key settings such as schools and workplaces can be used to improve health. Our second guest speaker, Dr. Judith Lynam, will explain how an innovative model, the Richer Social Pediatrics Initiative, is improving the health of a community with high levels of poverty and marginalization. And our final guest speaker, Iglika Ivanova, will look at opportunities through the tax system to reduce poverty, which can be a powerful lever for reducing childhood vulnerability. So that's an overview of the webinar, but before we start the presentations, we'd like to start with a question about you. We'll put this up as a poll and post the results. And if you see that you fit into more than one category, just choose the one that's the best fit for why you're joining in today. We look at the poll. We've got a few minutes. Everybody is voting. We get to see how many are voting. Okay. Well, it looks like 43% are interested in services and programs to reduce chronic disease, and the next one is 30%, all of the above. So we've got people involved in many different facets of chronic disease prevention. So now I'd like to move to an overview about the BCHLA report on the path to better health. And the report is in 3 sections, and I'll also remind you that the report is available on the BCHLA website if you haven't already had a chance to have a look at it. The first part looks at some of the achievements and milestones of BCHLA over the past 10 years, including our investments in community development and healthy living. Initiatives in 233 communities across the province, which engaged nearly 37,000 participants, and are estimated to have impacted 1/4 of British Columbians, so quite a reach. Part 2 provides a snapshot of chronic disease in recent years and looks at some of the protective factors that keep us healthy and the risk factors that contribute to the burden of chronic disease. And in this section, we also explore the interrelationship between chronic diseases and mental health, something which our first presenter, Stephen Smith, will discuss in greater detail. And we also look at how socioeconomic conditions contribute to health and how disparities in income and education create a health gap. And finally, in Part 3, we look at a range of actions that include both universal approaches as well as approaches that are targeted to specific populations with higher risk profiles. To start, we borrowed this vision of health and well-being from the First Nations Health Authority. We think it does a great job of really illustrating the dynamic range of influences that contribute to health and well-being, something that we all really need to attend to. So let me go through the next set of slides quite quickly. As I mentioned before, BCHLA set out to get a sense of how we're doing when it comes to chronic diseases in BC. And this is a snapshot of a few select chronic diseases that we chose, as they are good examples of conditions that can be modified by healthy living. And we'd like to recognize the assistance of the epidemiologists from the Provincial Health Services Authority, the Ministry of Health, and the Cancer Prevention Center to get these figures. So you'll see on this one that hypertension has, in fact, we've seen some reductions in that as well. As you also can see, as we look at the incidence of heart diseases generally over the past decade, we can see a trend line that is flat or declining. But I would like to remind everyone that these are incidence rates, and incidence refers to the new cases that are diagnosed within a year. So there still are increasing total amounts of people that have some of these diseases, but we are seeing the incidence rate declining. And again, with diabetes, we hope what we are seeing in 2008-9 is a flattening or a start of a decline, but we'll have to see how that works out. Then we look at the provincial distribution of chronic diseases across BC. Here we're looking at how diabetes plays out across the province. The light green areas have lower rates, and the darker the green, the higher the prevalence. And I think this was one of the most interesting aspects of the report because it really points out the significant differences across the province of many of chronic disease and risk factors. And unfortunately, there are disparities, and some areas are really experiencing higher disease rates for multiple conditions. We flag this because we see it as a potential guide for planning targeted and future interventions. For example, smoking. When BCHLA was first formed, we were largely focused on behavioral risk factors of smoking, healthy eating, and physical activity. We can see here we have slowly but surely been making progress with tobacco control. But while we have a 15% average across the province, probably the best in Canada, and great progress, when you start going into the details by region, there's a range of 9.9% in Richmond, the best, to a high of 24.7% in the northeast of British Columbia. So a huge range. And even within health authorities, for example, Island Health, there's a low of 12.7% of smokers in the south, but 23% in the north. So again, I think that is guiding us to where we need to focus in the future. On vegetable and fruit consumption, again, it hasn't changed very much over the decade. 41% consuming their suggested servings each day, so we've got a lot of more work to do. And interestingly, when you look at the breakdown, Kootenay Boundary has the best. They've got the highest rate with 51%. Again, the Northeast has the lowest with only 34%. With physical activity, again, not a lot of change, although I should mention again that the regional breakdowns do give some interesting examples. For example, the region with the highest rate of folks being moderately active is the North Shore Coast Garibaldi, perhaps because they're close to the mountains. And then there's the lowest is in Richmond with only 52%. And you recall that Richmond was the best on smoking, but the worst on physical activity. And then finally on overweight and obesity, we've obviously got a ways to go. The average is 46.6% in British Columbia, but a wide range. Vancouver is the slimmest, only 33%. I've got bike to work week this week, maybe that helps. Worst is the Northwest with 64.7%. So again, we really need to take into effect these changes. Let us move now to some of the other issues. We talk about physical and mental health connection. And Stephen Smith is going to go into this connection in more depth, but we know there's a bidirectional relationship between chronic disease and mental wellness. And we certainly know that those with mental illness have a higher risk for chronic disease, and that mental wellness can decline with the onset of chronic disease. We talk about the health gap as well, and there's a strong base of evidence, provincially, nationally, and internationally, that shows that socioeconomic status has a powerful influence on health status. And BC alone is not alone in this, but we'd like to see BC becoming more of a leader in closing this gap and improving health equity. And we make a number of recommendations in that respect. So finally, in the third part of the report, we have a list of recommendations to actions that we think could move us along the path to better health. And we also indicate who we think could be responsible for moving these ahead. Our guest speakers will give you a briefing on a few of these. But we'd like to note we've made some success over the past year, and we need to build on these. But to maintain the progress we've made, we'll have to keep up our commitments to healthy living. And looking at the big picture, we believe it's really important to continue the commitment of an all-of-government, all-of-society approach. It's not just the health sector that can move the dial in this area. And we need to continue the development of local capacity to address the needs, issues, and local conditions for health. And we need to continue investing in health-promoting policies and infrastructure. The report also includes recommended actions to look at place-based. So we are going to be talking about some of these again. We need to look at healthy start of life with early childhood. We need to look at workplaces and schools. Firstly, First Nations. There's a tremendous needs and opportunities. We also need to look at where information technology is leading. Lots of opportunities there. And finally, again, to emphasize this is a whole of government, whole of society challenge. So again, that's just a brief overview about our report, and I would certainly recommend that if you haven't had a chance, go onto our website, www.bchealthyliving.ca, to see it in its full. So now we'd like to move on to our first guest speaker, Stephen Smith. Stephen is the Director of Mental Health Promotion and Prevention of Mental Disorders at the BC Ministry of Health. His portfolio includes policy oversight of upstream mental health promotion and prevention efforts focused on building individual and community strengths, capacities, and resilience. So Stephen, over to you.
Thanks, Mary. I'm really pleased to be able to speak with you all today about this topic, which you might gather from my job title and Mary's introduction is obviously pretty important to me. I was very encouraged to see mental health woven into On the Path to Better Health, as I firmly believe that we need to adopt a comprehensive and integrated approach to promoting optimal mental and physical health. I often like to start discussions like this with the illustration that you can see on your screen right now. This was created by the province of New Brunswick to act as a mascot to support their provincial healthy living strategy. They call it their Wellness Buddy. What I like about it is that it really illustrates that efforts to support overall wellness need not only to consider but be led by efforts to support positive mental health. It's really the dimension at the forefront. This morning I'll be walking you through some conceptual considerations related to positive mental health and well-being, placing them into the context of provincial policy and opportunities for action, and then looking at some exemplars of action in key settings. Let's go on to the next slide. So let's begin by looking at this connection between mental health and physical health. And Mary started us along that path with her opening comments. There's a well-established body of evidence that's linked mental illnesses with physical health problems and chronic diseases. For example, a number of mental disorders include significant physical symptoms which illustrate this mind-body link. And what's interesting is that it may actually be the physical symptoms rather than the psychological symptoms and impact that drive affected individuals to seek out care for the first time. We also know that there's a strong association between mental health problems such as depression and anxiety, which incidentally are affecting people in industrial nations in epidemic-like proportions at present, and chronic diseases such as asthma, cardiovascular disease, and diabetes. And while the causal relationship between mental and physical illnesses is still not completely clear, we're still not sure in every instance which comes first in terms of that chicken and egg kind of relationship. It may be that it's dual directional, and Mary indicated that in her opening remarks as well, meaning that, for example, chronic untreated depression could heighten the risk of diabetes, and vice versa. Additionally, complicating matters, there's also a strong association between many physical disorders and adverse health activities like smoking, problematic use of other substances like alcohol, overeating, and physical inactivity. So we know that the connections between problems in the mental and physical domains cannot be ignored. What's really interesting for me, though, is just to flip things around, we are also starting to get a tangible sense of the potential protective influence of positive mental health. For example, a recent study from the United States examined data collected over 10 years through the Midlife in the U.S. study and found that the group of individuals in the study not benefiting from positive mental health had an increased probability of mortality after adjusting for known causes of premature death like cancer. Next slide. So I think this emerging work really underscores the need to re-examine our collective understanding of what is mental health. While mental illness presents a really very real and growing burden for many individuals, families, and communities, a burden that challenges us to rethink traditional responses and the reach of services, we also need to attend to the needs as they relate to positive mental health. I think it's important to start with this definition of positive mental health as advanced by the World Health Organization in a 2006 publication. They stated that mental health is not merely the absence of mental illness, it's an essential resource for daily living and the foundation for effective functioning from cradle to grave, enabling people to experience life as meaningful and to be creative, productive members of society. This is a definition we've embraced conceptually here in BC as it moves us from a place of consideration and corresponding response that is almost exclusively focused on problems to one that also considers needs in the context of individual, family, and community assets and strengths. It underscores the need to develop and support those assets and strengths not only to offset the risk of mental disorders and related problems, but also as an important investment in healthy and harmonious families and communities. Next slide. I need to recognize that this focus on mental assets, strengths, and resiliency is a bit of a leap conceptually for most folks. So to help to bring this to life, I find it helpful to consider mental health and corresponding intervention and action in the context of a conceptual model that was originally developed by Health Canada in the 1980s and that subsequently has been expanded and refined by an American researcher named Corey Keyes. So let's go to the next prompt. The model starts with a single continuum that represents our traditional understanding of mental health. Next. This continuum reflects a range of experiences of mental illness, from that of no mental illness at one end to that of chronic, persistent, and potentially debilitating mental illness at the other. A helpful continuum, but exclusively focused on problems. Next. What's different about this model is that it continues, it challenges us not only to consider the needs and priorities as they pertain to mitigating problems around this continuum, but it also introduces a distinct perpendicular continuum that reflects the range of experiences and opportunities associated with positive mental health and well-being. Next. According to Keyes, the endpoints of this continuum reflect a state of optimal mental well-being, which he labels flourishing, and a state of the lowest levels of mental well-being, which he calls languishing. You can see that at the bottom. Here in BC, we've chosen to use terms that are easier to grasp and understand. So we use thriving rather than flourishing and surviving rather than languishing to represent the two ends of this continuum. Next. So the dual continuum reflects distinct but limited ranges of experiences and helps users to understand that they need to consider needs across both continua when planning interventions. The continua also define quadrants that can be very helpful for this purpose, and you can see this green quadrant defined here. This would reflect the needs of people that have little to no experience of mental illness and are benefiting from strong mental well-being. This is obviously a group that would likely require interventions of very low intensity in order to enhance their existing strengths. Next. But in contrast, this quadrant reflects a range of experiences related to mental illness and low levels of mental well-being. So our efforts with this group of people would likely require interventions of greater intensity, interventions that are informed by specific risk and protective factors and the determinants of these health status inequities that they experience. Next. Likewise, the remaining two quadrants define similar opportunities for intervention and action. So it's a helpful model for us to place our opportunities and our actions within. Next slide. So the dual continuum model gives us a conceptual basis for consideration of needs related to positive mental health and well-being. I need to acknowledge that it can also be challenging for folks to contemplate how they might influence mental health and well-being in a positive way. And correspondingly, I'll touch on what's encompassed by mental health promotion. As an approach, mental health promotion seeks to empower individuals and communities so that they may experience more control over and mastery of various aspects of their lives. It focuses on efforts that serve to improve self-esteem, enhance personal capacities to flourish, build resilience and coping skills in the face of challenging circumstances or situations, and foster social inclusion and connection in order to reinforce family and community supports. In many cases, the specific approaches to reach these ends aim to modify the social and economic environments that can influence mental health, both in a positive way and in a negative way. So to this end, efforts to promote mental health quite commonly focus on the whole population or very large subsets of the entire population. However, efforts to promote mental health may also be appropriately focused and intensified to address needs of specific populations that experience some vulnerability to mental ill health or substance use problems, or have an established problem or disorder already. Next slide. So I'm wondering actually if we want to pause just to do a brief polling question at this point. Based on how you understand work related to positive mental health, I'd like to ask you to indicate whether the following statement is true or false. Mental health promotion and prevention of mental illness are just different ways of describing the same efforts. Let's take a moment just to respond to those questions. Okay, and so the vast majority of respondents have actually indicated that this is a false statement, and they're absolutely right. Although these are complementary and at times may employ approaches that are somewhat similar in structure, the primary difference between mental health promotion and prevention of mental illness lies in the intended outcome of the work. Mental health promotion activities and initiatives are almost entirely focused on building or enhancing strengths, capacities, resilience, and positive emotional states. Whereas when we're talking about interventions that are intended to prevent a mental health problem, they tend to focus on mitigating vulnerability, however that vulnerability may be determined, and opportunities that may lead to the development of mental health problems by extension are prevented. Next slide. So I think it's also important to highlight how provincial policy is supporting this movement to consider mental well-being. I imagine that most of you may know that the province released a 10-year mental health and substance use plan in November of 2010 called Healthy Minds, Healthy People. What you may not know is that Healthy Minds, Healthy People lays out an ambitious transformational agenda. including a suite of 63 actions that require efforts from 7 different ministries, multiple sectors, and stakeholders from various disciplines. The plan prompts us to consider needs and opportunities beyond our traditional policy focus on the most chronically ill in order to promote positive mental health and well-being, prevent potential problems, and wherever possible before they occur, and to intervene with help and support earlier when problems are unavoidable. Healthy Minds, Healthy People suggests that in order to manage the scope of this transformation, we need to focus our efforts, particularly as they apply to promotion and prevention, on developmental stages and corresponding stages of transition. The plan also includes an emphasis on key settings that serve to maximize the reach of these efforts at stages across the lifespan. These settings include home, schools, and the workplace, and I'll wrap up the final part of my presentation with a quick exemplar in each of these 3 settings. Next slide. In the setting of home, I'd like to focus on the BC Healthy Connections project, which is a project that's available through public health in a number of municipalities in BC to young, low-income, first-time mothers and their families. The BC Healthy Connections project has been established specifically to evaluate outcomes associated with introducing the Nurse Family Partnership program here in British Columbia. The Nurse Family Partnership, many may know, is a long-term home visiting program that offers more intensive support than the universal perinatal supports available currently through public health. The program has demonstrated really impressive results in other jurisdictions for participating moms and their children. Results that include improvements to mental health and well-being, improvements to physical health, and improvements to social and economic stability for the family. Given BC is the first Canadian jurisdiction to offer Nurse Family Partnership in a broad-based manner, the evaluation undertaken through Healthy Connections BC project, which is led, incidentally, by the Children's Health Policy Centre at Simon Fraser University in partnership with McMaster University, will assess whether outcomes for families here are consistent with those measured to date in other countries. This evaluation will guide decision-making related to sustaining and expanding the program in BC and potential replication elsewhere in Canada. Next slide. In the setting of schools, I'd like to highlight some work underway at present that's being led by the Directorate of Agencies for School Health, or DASH-BC, and the multi-sector, multidisciplinary BC School-Centered Mental Health Coalition. This project is focused on identifying best practices associated with higher levels of student-reported school connectedness, disseminating those practices to other school communities, and fostering projects to apply the practices. The work is based on a strong foundation of research-based evidence that suggests school connectedness is not only a strong determinant of positive mental health and well-being, but that it also supports other positive health outcomes as well as educational attainment. At its core, this project embraces the proven comprehensive school health approach, which is advanced by DASH-BC and illustrated here through this figure that they've provided to us. And by virtue of this, it strives to benefit all students within a school setting, and by extension, all staff and adults within that setting as well. Next slide. And so finally, in the setting of workplaces, I'd like to highlight some work underway in order to develop an action plan to improve psychological health and safety in BC workplaces. This work's been inspired by some recent legislative changes here in BC, which expanded provisions for workers' compensation to include mental disorders caused by workplace stressors such as bullying and harassment, and corresponding policy requirements from WorkSafe BC related to prevention and response to bullying in the workplace. Recognizing that there's already a range of solid, evidence-based, made in BC tools and resources to support positive mental health and well-being in workplaces, a group of key stakeholders from government, the academic sector, and non-governmental groups such as the Canadian Mental Health Association, the Canadian Cancer Society, and the BC Healthy Living Alliance have partnered to develop an action plan to extend the reach of these resources. Part of this work will examine specific platforms or levers that are required in order to reach specific sectors that have a greater reported incidence of problems associated with risk factors such as bullying and harassment. So really adding intensity to some of the resources that already exist in order to address areas that are particularly problematic. Next slide. So that takes me to the end of my formal presentation. I really appreciate your attention, and I'm happy to answer questions that you might have.
Great. Well, thank you so much, Stephen. You really provide us with really the context and then some great examples of initiatives that are underway with the nurse practitioner and the schools and the workplace. I would just like to mention that BCHLA is involved in a new Working on Wellness initiative with workplaces in northern BC, Yukon, and the Northwest Territories, which is going to look at including both physical and mental health in an integrated approach. So now, colleagues, it's time for you to send us your questions for Stephen, and we have a couple to get started with. I think the first one, Stephen, is there any early data on the nurse-family partnership and its results, and is it encouraging?
We've only just started the formal evaluation this past fall, and it was started fairly late in the fall. I think the official launch date would have been the end of October or beginning of November. So it's too early at this stage to point to any formal evaluation results. We've certainly had some anecdotal evidence from the nurses who have been working with practice or guiding clients in advance of the scientific evaluation starting, that the program has been really well received by participants here in British Columbia. So the acceptability of the program and its adaptability to Canadian context are certainly, we have some anecdotal evidence that certainly lines up to say that that's pretty much in place here in British Columbia, but it's still too early to determine what kind of outcomes we're looking at in terms of a population benefit at this stage.
Right. Well, we'll look forward to further results on it because it certainly looks like a really important program. Another question on how are the staff or the teachers being supported under the DASH school mental health program? Is there training or are there supports being provided to them?
It's a multi-phased project, and the first phase of the project is actually identifying schools that have had a strong track record of success with school connectedness already. So it's pulling the best practices out of the field and providing those schools with a bit of resourcing in order to find a way to tell a story about those results. So to record their experience and the steps that they undertook in order to foster school connectedness, schools are enabled to create a short video, to develop some print resources, to tell their story online, whatever format they choose to take. And we're really encouraging them to work with the students in this school as well to tell that story. Will constitute the first phase of the project. And then the second phase will be looking at opportunities to disseminate that, whether that's through traditional knowledge exchange activities like webinars or like provincial meetings or through a website, or whether it will be through non-traditional methods that are identified through that storytelling kind of process. And an additional component of that second phase will be working with schools who wish to actually apply these best practices. And we're taking an unusual approach. We're going to work with the school communities to pair them up with some of the more experienced school communities in a mentor-mentee kind of relationship and provide them with a little bit of funding to support that relationship developing and resulting in the application of best practices in the second phase schools.
Great. Now, Joan is asking, and this question I think maybe is much to our next two speakers, but you may want to comment on it, Stephen, that poverty seems to be at the root of many of these issues. Why not invest more in social assistance?
Well, it's a good question, and certainly in the context of the BC Healthy Connections project and the Nurse Family Partnership Program, the target population is definitely low-income, first-time moms and quite young moms. So we're recognizing that there are some significant inequities that are related to the social determinants of health there. And a good portion of the curriculum in that particular program is focused on working with the mom in a coaching kind of way to link her with resources, to develop plans around educational aspirations or career aspirations, and to enable those wherever possible. So although it isn't attending to the determinants at a systems level, the response is recognizing that certainly there are opportunities to find ways to mitigate the impact of those determinants. At a systems level, we're certainly, when we're talking about early development for young children, we need to be finding ways to address some of those contributing factors that result in the inequities, the social inequities and the health inequities that really defy a healthy developmental trajectory for young children. So I'm hopeful that the early years strategy that was announced about a year and a half ago by MCFD and is realizing some early years centers now across the province will be a platform that we can use to help to manage that on a more systemic kind of level.
Well, thank you so much, Stephen. Actually, that's a great segue into our next speaker, and I would like to introduce her now, Dr. Judith Lynham, because Judith is a professor at the UBC School of Nursing and the research lead for the Richer Social Pediatrics Initiative. Oh, and that stands for, watch this, Responsive, Interdisciplinary, Coordinated Health, Education, and Research. That's why I call it Richer. Joan has been the primary investigator for numerous studies that have examined the Richer model and its potential for improving health equity and healthcare access in a community with high levels of disadvantage. So, Judith, welcome, and please proceed.
Thank you so much, Mary, for the invitation to talk about this very exciting project. So, I'm trying, in this title, I'm highlighting some of the features of the Richer initiative that I think offer some guidance in how we as clinicians, we as community members, and others concerned for addressing inequities in health might work together. So it's an intersectoral partnership, and we enacted it in the inner city, but I think there's lessons here for other contexts. So I'd like to go to the next slide, which does spell out our acronym. We have some wonderful people working with us who are very clever in their use of terms. So we started with a focus on children in the community context, and it really was very much about creating being responsive to the health and developmental challenges faced by these children. In the next slide, I just want to illustrate the kinds of partnerships that we formed, that were formed to enact this initiative. So some of them were partnerships specifically around the research, others were partnerships in the delivery of the outreach model of practice that I'll describe. But you can see that the intersectoral nature of it, and there are a number who aren't named here, which you'll begin to see. But so we have funding from a variety of research sources. We're working collaboratively with a number of community-based organizations that are in place in the neighborhood. It's an academic partnership, and it also includes partnerships with health authorities that have jurisdiction around the care of these children and families in this inner city neighborhood. So for the next slide, I just want to tell you why we began the work that we did in this neighborhood. And when I say we, I speak as a researcher who was analyzing a set of problems and also had access to some ideas, so some theory, some other practice examples, and I partnered with clinicians and community groups. But the issues that we were specifically looking at were data that showed marked inequities in children's health. So those inequities were manifest in a high incidence of complex health issues and a high incidence of developmental challenges, both of which obviously influence health over the life course. And also looking at the incidence of those issues in a neighborhood context that had significant poverty, marginalization, and social exclusion. And those two, marginalization and exclusion, are very strongly associated with poor health in population studies. So it tells us that whatever we're doing, we need to be dealing with the health issues, but we also need to be dealing with the social context. The other thing that was evident in place in this neighborhood was that there were multiple barriers to healthcare access along the continuum. So there were structural barriers to access to preventive services. So even though there's universal programs for prevention, we were hearing that the public health folks were having trouble accessing the population, so getting kids immunized, getting them assessed developmentally, etc. And there was also a significant access problems around primary care, which then of course influences access to specialized services because you need referrals. So those combinations of system issues were operating in this neighborhood. And what we saw in terms of the access to primary health care was delays in diagnosis, delays in access to treatment and supports, lack of integration and with specialized services. So sometimes children might get a specialized treatment, open heart surgery, some neurological condition treatment at a specialized center, then move to this neighborhood or be in this neighborhood but have no primary care follow-up. So there were clearly structural issues. And then we also heard there was a lot of use of emergency services for non-emergent but significant health issues because of this lack of access to primary care. So all of these things paint a fairly challenging picture, and they're all associated with poor health in childhood, but also poor health over the life course. So that's why we started the work that we did. So on the next slide, so what we were trying to do then in the introduction of the Richer Social Pediatric Initiative was we were trying to foster timely access to health care across the spectrum, from primary care to specialized services, for a population of inner city children who had disproportionately high rates of developmental vulnerability as a consequence of their social and material circumstances. So the next slide is a map of, some of you or many of you will probably have heard of the EDI, which is the Early Developmental Indicators. And this mapping work is work that was done by colleagues of ours at UBC under the Human Early Learning Partnership. So this group has mapped developmental vulnerability of all the neighborhoods in BC, and in fact there's maps for many of the provinces in Canada, and this technique's been used in many other jurisdictions now in the UK and Europe and Australia. But what I want, so these pie charts or star plots as they call them. The bigger the slice of the pie and the bigger the circle suggests the higher levels of developmental vulnerability on different domains. And the neighborhood we were working in, or we started to work in, is at the top of this map, so the Strathcona and Grandview Woodlands neighborhoods. So this is a jurisdiction, this is just the map for Vancouver. And this is the neighborhood in Vancouver that has one of the highest levels of developmental vulnerability. And this is a historical map. So this is 6 years ago, I think. That Strathcona neighborhood was the highest developmental vulnerability in the province at the time. So it seems that this was a good sort of neighborhood context to begin our work in. So in the next slide, when we were thinking through how would we try and evaluate what impact this initiative might have in our research, so we were looking at indicators of vulnerability, developmental vulnerability, and we were looking at indicators of primary health care access. And we wanted to know if this approach that we were introducing would work for those people that we were targeting, so the people who typically are the hardest for health professionals to connect with, it seems. So we wanted to see, understand what was going on with those families and see if we could connect with them. So in the next slide, so what we ultimately did in order to achieve the outcomes that we did was to basically start to change the structures that of service delivery and focus particular attention on the processes of care. So what that really means is, so what we ultimately learned, what was happening and why it was working, was that the ways the clinicians and the clinical team partnered within the community context, they began to learn how to dismantle structural barriers, which I'll talk about, and also social barriers to access. And this depended a lot on their capacity to show respect for the people in the neighborhood and to build trust with those folks. So I don't know, keep in mind the structural barriers to access, because that's what we typically think about when we think about access. We think about cost, proximity, scheduling, how nice, where a facility or a practice site is located. But we learned that the social barriers were almost more important than that. And by that we mean families talked about poor relationships over their life course. So parents might say, they had been prejudged by professionals, and this could be social workers, this could be physicians, this could be nurses, this could be teachers, this could be a lot of people over their life course who sort of dismissed them or didn't respect them, and so they were very, very cautious in their relationships with formal systems. So there was a real need to sort of feel that they could be heard and engaged with. So that became a very important part of how the clinicians engaged. Building clinical relationships that extended and enriched family social relationships was also an important part. So here this gives a recognition to the importance of our friends, family, neighborhood as creating a buffer, if you will, or protective influences, helping us, expand our resources when we're in trouble. Like if any of us think about, if we have a flat tire, or we had got locked out of our house, who would we call? We would probably have a number of people we could call. A lot of these families facing, oh my goodness, who can look after my child? The list of people was almost non-existent. So that, those are just simple examples of how the initiative through the partnership helped build those relationships. Ensuring parents are supported to nurture their child's development. So there was building parental knowledge and skill, but also people around building the capacity of the neighborhood and their social networks. And then also engaging with people in ways that they could understand what we were taught or what the clinicians were talking about. So let's go to the next slide. So basically the partnerships really set out to complement and enrich and extend services. So the formal system, work together in partnership with informal systems, and through that we managed to demonstrate some good outcomes. So I'll go to the next slide. So just to give an example, so in the range of clinical services included primary healthcare clinics led by nurse practitioners. So these would be in, they were both by scheduling appointments, but also there was drop-ins. So there was these were localized or located in neighborhood sites, including schools, including daycares, including community centers, places that children and families felt safe, and where the clinician then built a relationship with the other service providers, so the other, like the educators or the daycare providers. At the same time, we have pediatric specialists who work in an outreach model as well. So they came to the place-based venues, so they worked collaboratively with the primary care nurse practitioners. And then we also had a weekly, and we continue to have a weekly community table. So here's a place where any people that are community members, but also members of community organizations that are working with us, it's a problem-solving table. So people come together and put on the table an issue that doesn't seem to be working, and we work through how to, if we need to tweak where or when services are provided, or if we see that there's certain groups in the neighborhood who aren't able, to engage and access. So then we develop some additional strategies. So for example, at the bottom of that slide, there's some examples of ways that we refined or developed some new points of engagement. So BFF is Bright Family Futures. What we were seeing, what the community was telling us was that some of the young families at dinner time, there was a lot of stress, there was a lot of tension, parents needed some support, often single parents without, they needed to get dinner together, and it became a kind of fragile time in the neighborhood family. So the community said, well, why don't we bring everybody together? We can have a family drop-in. We can provide childcare. The clinicians come and they can build relationships with the families, and if there's a need for clinical encounters, then they follow up with that. There's an education piece, so there's a meal, family support, building a network at a vulnerable time. So that happens once a week. And Off the Grill is another example of trying to engage with very vulnerable young adolescents who were hanging out in the neighborhood because they weren't welcome in some of the community spaces, and yet were very vulnerable to exploitation by others. So we partnered with the police, we partnered with community centers, we partnered with the clinicians. So the clinicians worked with these kids to start a drop-in meal program in the park. And the kids are now preparing the meals, shopping, and it's moved indoors. It moved indoors in the winter, so these kids now felt welcome and safe that part of this was their place. So it was a first stage of trying to engage with very at-risk kids in order to get them connected with the kinds of services they need. But those ideas came out of conversations that included the community and the clinical team. Okay, so could we have the next slide, please? So here, this is a very busy slide. We won't be able to speak to it all, but it is a logic model that we developed to try and illustrate how this approach, what is it that we were doing, and what are some of the outcomes, what are the ways of engaging. So the taupe sections in the middle are what the clinicians were actually doing, so with individual children and families and with organizations. And the processes were linking in and linking across the very siloed service delivery models that we have for, education, and, people work in sectors, but they don't necessarily work across. So the clinicians were often basically convoys to connecting and building links for individuals, but also across organizations. And the outcomes, all of the solid lines and the bold, we have demonstrated, we have research outcomes to demonstrate those things. So I'm going to talk a little bit more about the bottom line in the next few slides. So basically, in the research program, we sought to explicate what is social pediatrics, what actually is it about, and then also understand what influenced access to health care in this kind of neighborhood context, and what were the things about this social pediatrics or richer approach that actually achieved, fostered access. And the next slide. So so I'm not going to go into all of the methods and things and the tools that we use, but I can answer those questions if you're interested. But basically, we established in the both qualitative and survey data analysis of the data that we gathered that relationships, trust, and respect fostered access for this population. Partnerships were effective ways of dismantling silos across the health sector, but also to resources outside of the health sector. And one of the things that was very important was that the partnerships we established, particularly with the community-based organizations, was that these enabled families to access services to address the social determinants of health. So there was a really important need around accountability. So the next slide, I'm just going to wrap this up. So we demonstrated that it had a very it fostered access for exactly the target population that we were aiming to, and it had very high ratings of access, continuities of care, responsiveness of the clinical care model, and the relationships between the clinical team members, and those relationships had a very, very high association with empowerment. So all of these are indicators of quality primary health care. So I'm going to skip down to this. Basically, yes, we fostered access for the families that we were targeting. And the next slide. There were the specific characteristics that were strongly associated with the positive outcomes. And the next slide. This, we can skip over it, but it just reinforces what was important in the care. Next slide. Again, we can go to the next slide. We've seen that one. Next slide. Okay, so this is, in addition to the outcomes that we documented, the EDI, or the Human Early Learning Partnership, also did the most recent wave of the EDI for the province. And this is a pattern of the trends for the different developmental vulnerabilities for the province. So you can see there's a trend of increasing vulnerability, and Vancouver is the black line in that trend. But if you go to the next slide, you can see that our neighborhood, which is now the Strathcona Grandview Woodlands one, in our neighborhood, the trend has been reversed. So in this neighborhood, with the sort of place-based approach that's been taken here, so this includes what we've been doing in the Richer program, but also what the community partners have been doing, has led to a 25% reduction in developmental vulnerability in this neighborhood. So we see that as a very positive evidence of a very positive outcome of this place-based approach. So I'm going to leave it there. There are some additional slides that we could come back to if people have questions.
Well, thank you so much, Judith. And as you mentioned, your full presentation will be on our website. So folks on the line, don't worry, you'll have a chance to look at it in more detail. And I just want to say how much we at BCHLA admire and are impressed with your work of the Richer team. It's just great. We'd like to see it replicated in other communities that also have high levels of poverty and marginalization. But given our time, I think we're going to move right on to our third speaker and then hopefully have some time at the end for questions. So let me introduce Eglika Ivanova. Eglika is an economist and a public interest researcher with the BC office of the Canadian Centre for Policy Alternatives. She researches and writes on issues in healthcare, education, social programs, and government finance in British Columbia. And her particular interest is in trends in income inequality, low-wage work, and the integration of immigrants. She's also the co-author of the Livable Wage Study, the most recent version of which was just released last month. So, Eglika, please go ahead.
Thank you, Mary. And thanks, everyone, for being here and giving us your attention this morning. I would like to approach the question of reducing the health gap that Mary talked about in her opening remarks through a more direct manner through the tax system. And this is something that federal and provincial governments can do. And it's an approach that we usually don't talk about when we think about improving health. But given that we know how important poverty and income are as determinants of health, I think maybe it's time to look a little bit more systematically at how we can affect health through reducing poverty. Next slide, please. So we know that there's a very strong relationship between poverty and health inequities or health gap. And that's true even in countries with 100% health insurance coverage like Canada. So it's not an issue of not having insurance coverage or not having publicly provided health care. It's an issue of access. And you can see on the slide there's a growing body of research that links low income to unfair and unavoidable, actually, differences in health status in basically any measure of health that you can think of. And that includes mental health and physical health. And the gaps in health that are caused by income disparities or socioeconomic status disparities are actually quite large. The higher incidence of chronic conditions, of disability, they are not just small differences, there's huge differences. And to give you just one example, a recent Canadian study found that men born in the lowest income areas of Winnipeg have an average life expectancy of 10 years less than men born in higher income parts of the same city of Winnipeg. So this is a huge difference, 10 years of life expectancy. And it's much bigger than what Canadian researchers have found the difference would be if we actually eliminated all cancers. It's estimated that life expectancy would increase by 4 years in Canada. So poverty, marginalization, and social exclusion actually have a much bigger impact on life expectancy than cancer and some of the chronic conditions we talk about. And that's why I believe it's very important to look at poverty, and particularly in the demographic of children, because research on early child development related to the EDI that, as Judith talked about, has shown that particularly important period of the lives of children is the first 6 years of life, and poverty in those days or at that stage of life has negative consequences that can be potentially lifelong. And in fact, the research has shown there's long-lasting consequences of early childhood poverty, even if children's families are able to escape poverty in later childhood or adolescence. So poverty in early life is very, very toxic for children and important to combat. Next slide. And what we see in the next slide is that BC in particular has a strong interest here to act fast, because we are the province, unfortunately, with the highest child poverty rate in Canada, and that has been the case for 10 years running. We have either been the highest or the second highest child poverty. And Canada as a whole doesn't rank well compared to other developed countries. We are at the bottom of the pack in terms of child poverty. We have much higher child poverty than we should, considering how wealthy a country we are. Next slide shows that we don't just have a lot of people living a little bit below the poverty line, but when we talk about child poverty, this is the average depth of poverty. So it's quite high. Most children in female lone parent families live about $9,000 below the poverty line, and two-parent families are about $14,000 below the poverty line. Those are large numbers, so we're seeing significant levels of deprivation here in BC. And an important issue to consider, it's not just the single-parent families that are a problem here. It's a lot of poor children live in two-parent families. In fact, there's more poor children in our province that live in two-parent families than in single-parent families, simply because there's more two-parent families. So we really need to be careful when we design interventions that we cover all children living with these vulnerabilities. Next slide. As Mary mentioned in her opening remarks, it takes a whole community to solve this big problem. It should be an all of government and all of society approach. The private sector has a role as employers to pay appropriate wages and provide flexibility in working conditions. The nonprofit sector is very important. Community groups are very important. But what I would like to talk today about is the role of government, and in particular the federal government. Next slide, please. So governments do play a very important role as it is. This slide shows the percentage reduction in child poverty rates that are due to government transfer payments. So things like GST credits and government child tax benefits reduce the Canadian child poverty rate by 43%. What this means is we would be seeing 43% higher child poverty rate if we just looked at market outcomes, but government transfers are important. And another important thing to note from this slide is there's a very wide range of programs available across different provinces. Some provinces are better at reducing poverty with their tax and transfer systems, and some provinces have room to grow. And our province here, BC, has quite a bit of room to grow. Our tax system and transfer system doesn't do as much in reducing market poverty as other provinces. Next slide. So the system of federal child tax benefit in Canada is based on 4 main planks. The biggest one by far is the Canada Child Tax Benefit. We spend about $10 billion on the Canada Child Tax Benefit. The maximum amount available is up to $3,600 per child under 18. It is income-tested program, but it is very inclusive. About 90% of families with children under 18 in Canada get a supplement from the Canada Child Tax Benefit. So it covers a wide range of families. It does have a part of it called the National Child Benefit Supplement, which is targeted in particular towards low-income families. And you see here what the range of income is. So the maximum amount is available to families with income under $25,000, and the low-income supplement is completely phased out when you reach income of $44,000. Now, this is important because the Canada Child Tax Benefit provides a huge supplement to very low-income families' income and does a lot to reduce child poverty. The Universal Child Care Benefit is a new program that was introduced in 2006. It provides the same amount, $1,200 per child, but only for children under 6, and it is not income tested. However, it is taxable, and so we get into this paradoxical situation where most people have no idea how much they actually get because nobody goes through their taxes and then calculates what percentage of tax they actually pay on that $1,200. So most people have no idea how much they get, but most people get less than $1,200. Non-refundable child tax credit is something similar to the basic personal amount. When you fill in your taxes, you know you get to deduct an amount for every child under 18 you have. The key here, problem with it is that it's non-refundable tax credit, which means if you don't owe taxes, you don't get anything. So poor families who don't owe taxes get nothing, and non-poor families, regardless of their income, get $335 per child. And the last program, again introduced in the mid-2000s, is non-refundable child sports and arts tax credit. Again, poor families get nothing. Non-poor families get the same amount regardless of their family. So as you see, there is a variety of programs. It's complicated. Most people don't know exactly how much they get. And a lot of institutes like ours and community groups are supporting transforming the child tax benefit into the main program that will deliver benefits to families with children, and basically rolling all these other benefit programs into it. Because they might sound small, but the UCCB, so the Universal Child Care Benefit and the child tax credits actually cost about $4.4 billion a year. So they're huge programs, even though they don't provide a lot of support for the poorest families. So rolling those tax credits into one, increase the maximum available benefit per child to $5,400, increase the income threshold at which the low-income supplement begins to be reduced, because a family income of $25,000 is below most poverty lines of families with 2 parents and 2 children. So we really need to think about that. We need to require provinces not to claw back the benefits from the national child tax benefits from provincial social assistance programs, and British Columbia does claw back, if I'm correct, the benefits the families on welfare receive. And the net costs that are estimated, depending on how exactly you roll this out, but they're up to $4 billion a year. And that may sound like a big number, but when we put it in context, Canada spends a lot less than other developed countries on child support programs for families. And in fact, if we spend another $4 billion on child tax benefit programs, we would still be below the OECD average on spending for child tax benefits. So we definitely have room to grow, considering where the rest of the world is on that. Next slide, please. Why the child tax benefit in particular? I think it has key properties that make it very good at reducing poverty for Canada. It is inclusive and non-stigmatizing program. That is very important. About 90% of families currently with children currently get a benefit, and it should remain that way. We should have the same programs that do not stigmatize low-income people and forcing them to seek specific interventions. The other key property that is very important to me is that it is available to all Canadians regardless of where they live. Because some of the amazing programs that Stephen and Judith talked about that provide very intensive interventions and are probably very helpful in improving people's conditions are only available in BC or in Strathcona and Grandview, Woodlands area. And so if you don't live there, you don't get access to those amazing programs. So reducing poverty through a child tax benefit federally would be available to all Canadians. It will be indexed to inflation, which is what the benefit currently is, and it means it grows every year with inflation, as opposed to many other child or low-income subsidies that have been frozen. For example, welfare payments in BC haven't changed since 2007. The subsidy for low-income families, rental assistance hasn't changed since 2007. Subsidies for childcare hasn't changed since 2005. So indexing these benefits to inflation is a huge advantage that the tax system would allow us to automatically get. And it can be very easily administered. There's no additional application processes. There's no additional administration that needs to be set up. Just draw it through the existing tax system. And our estimates show that we could reduce child poverty by about a quarter from current levels if we increase the child tax benefit to $5,400 per child. Next slide. I just want to touch quickly on a tax reform that's being proposed currently, income splitting, which would actually not help at all and will worsen health inequities. If you don't know what that is the federal government has proposed to allow families of two parents and children under 18 to take $50,000 from the higher earning parent and report it as income for the lower earning parent in order to put that $50,000 in a lower tax bracket and pay less tax. What this means is that the maximum benefit of $6,500, which is way higher than the current maximum of the child tax benefit, for example, the maximum benefit will go to a single earner family with income more than $185,000. I would argue this is the type of family that least needs government help in raising their children. The benefits in generally are very skewed towards the richest families. The top 5% of families will get as much benefit from this program as the bottom 60% combined. And in fact, 86% of families with children under 18 in Canada would not get anything, either because they're single-parent families and have nobody to split income with. They're too poor. They're in the first tax bracket, so splitting income doesn't make a difference on your tax rate. Or they're dual earners with similar earnings, so they don't get the benefit there. And this is estimated to cost $3 billion to the federal government and another $2 billion to provincial governments in lost taxes. So I would say take these $3 billion and put them towards an improved child tax benefit. Next slide, please. Here's other areas of action for the federal government. And one of the biggest advantages or roles that the federal government has an opportunity to play is a coordinator for a national housing strategy or a national child care plan, or to help roll out amazing programs like the one that Stephen and Judith were talking about at the national level. Next slide. It is a matter of priorities. As I mentioned, we can afford it. This is a publication we put out every year. It's called the Alternative Federal Budget. And it shows that we could, with the same government budget that we have now, if we made different choices about spending items or taxes, we could lift 855,000 Canadians out of poverty. We could reduce the child poverty rate by 25%. We could boost the economy, and it won't have big implications on the deficit or provincial debt or federal debt. Next slide. The time is now to take action on this. I believe we are in a position to be a leader We can't afford to reduce poverty. We need to do that because poverty, marginalization, and social exclusion is not just a personal tragedy for the families who experience it. It costs our society. It tremendously increases the burden of poor health, and it's expensive in terms of health as well as crime and lost economic opportunities. So that's a study I did in 2011, estimating the cost of poverty in our province. Next slide, please. And at the end, I guess, this I want to emphasize again, as Mary said in her opening remarks, this should be all government, all society approach. So get involved as health professionals and as citizens. Here's how you might be able to get involved. And here's pictures of some people who have gotten involved. You might recognize in the lower right corner, John Miller, who has been a population health practitioner and a provincial health officer in BC in the 90s. He is very involved with that. So I highly encourage you to check this out. Thank you for your attention.
Thank you very much, Aglika. Of course, John has been a key member of our alliance over the years as well. And it's really quite remarkable to see what a difference in the tax and benefit structure could potentially make in the lives of those with the lowest income bracket. I just want to mention that one of our policy initiatives is to promote the use of health impact assessment of all government policies. And we believe that by applying a health lens to financial policy, that could lead to reductions in chronic disease rates and poverty rates in the long term as well. Now, given the time, we're going to open the floor up for questions. Please post your questions on the box on your screen, and we'll take as many as we can in the next 14 minutes. Let me start with the first one, which is for Judith. Can you please tell us where the original impetus for the Richer initiative came from? Was it a community organization? Was it a health authority? Or where did the big push come to do something different from what had been done before? Judith? Have we lost you, Judith? Well, let me move on to the next question, which is for
Sorry, can you hear me now?
Yes, we can.
Sorry, I apologize. The impetus came from a public health nurse who came to me and said, I see all these children facing challenges and I cannot activate the system to address their learning challenges, their developmental challenges, their health challenges. Is there another way we could work? Early childhood educator made a similar observation. So the three of us started talking about alternative ways of engaging, put some of the ideas on paper, and then we started to talk with key people in health authorities, people in the neighborhood, etc. And so in the end, we pulled together people who shared the concern and who were open to seeing if there was another way of working.
Great. Yeah, and Judith, another question for you. Do you work with public recreation, and if so, in what capacity?
So the City of Vancouver, in a sense, is a partner because many of the child care programs that we work with are located within, it came out of a community centers initiative around supporting early child development. So the neighborhood that had a community board that worked through their community center said, we want early child development to make that a priority. So how can we do that? So they developed some daycare programs that were accessible financially accessible and geographically accessible. They worked in partnership to create safe access to recreation and play because the neighborhood itself was somewhat problematic for children to be unsupervised in, etc. So there was definitely a part of that. Yeah, so I would say yes, that they are definitely at the table all the time.
That's great. Aglika, we've had a comment back from Pam just to indicate that in BC, income received from the Canada Child Tax Benefit is not deducted from income assistance recipients. I realize that's not all low-income families, but from income assistance recipients.
Oh, excellent.
Right. But also, Aglika, we're sort of wondering about other provinces and territories that have poverty reduction plans, and have they shifted the way they structure their tax and benefit system in order to alleviate poverty? And specifically in Quebec, Quebec's been able to reduce child poverty by 51%, and why is that so much more than what we've been able to do in British Columbia?
Those are great questions, and thanks for the correction about the child tax benefit not being clawed back in BC. I know that some provinces do claw it back, however, so it's important to consider. There are 8 provinces currently that have poverty reduction plans in place or are in the process of developing one, and BC and Saskatchewan are the only 2 provinces in the country that don't actually explicitly focus on poverty reduction in policy making. So a lot of them actually have chosen to focus on child poverty in their poverty reduction plan, and as you mentioned with Quebec and others, they are changing their system of taxes. Quebec has a very different system. They provide different child benefits, but they have a lot more flexibility on taxation because of the way they run things separately from the federal government. The other provinces that have very similar systems to BC, I would say one of the interesting examples is Ontario. They have also had quite a lot of success in reducing child poverty there since their poverty reduction plan was in place, and there they specifically focus on child poverty. So they have introduced a provincial Ontario child tax benefit that is modeled on the Canadian child tax benefit, and is very targeted towards lower income families. So what they provide is another $1,100 a year for low-income families with children, basically for children under 18, and that covers a lot of children there. Now, in British Columbia, the provincial government introduced a similar child tax benefit that will come into effect next spring, next April, but the maximum benefit is half of what Ontario is offering, so it will be $660 a year, and it will not be income tested really. It will be the same for all families with income under $100,000, and then families between $100,000 and $140,000 income will receive sort of slightly smaller benefits. But it's, as you see, it's a different approach. Ontario's giving more money to lower income families. BC is giving less money more broadly. So that's why you might expect a different result.
Right, yes. That in fact answers the next question we had was about that new tax credit program in BC that will be coming in. I want to move over to Stephen. You mentioned that WorkSafe BC has taken actions to address workplace bullying. Can you provide a little more context on that? And also, are there any early results or impacts of that as yet?
Yes, thanks, Mary. What WorkSafe BC has done is to respond to the changes in legislation with the introduction of a policy that requires all employers, all work sites to have in place specific approaches to addressing workplace bullying and harassment, both in terms of prevention and response. So the policy requirements are pretty specific, and they focus on those 2 specific aspects of risk with respect to mental health and well-being. The challenge, I think, that many employers face is actually how to implement those policies or how to bring them to life in a very sort of tangible way, given the specifics of their work sites. And the WorkSafe BC has correspondingly introduced a toolkit that supports employers, it supports human resource personnel, supports workplaces to actually introduce these policies, to introduce supports and structures within the workplace that mitigate the impact of bullying and harassment. Now, in terms of actual impact, measured impact related to that policy and those resources, I don't know of anything yet that's come out related to that. I do know that just in terms of the change in legislation, that there has been an interesting response with respect to workers' compensation claims that are related to mental disorders caused by workplace stressors. And some early suggestions emerging from that data are that industries like the construction sector, the health sector, and the hospitality and transportation sectors are all sectors that are overrepresented in terms of the claims that are related to mental disorders caused by workplace stressors. So that's informing some work happening at the table that's developing the action plan I referred to within my deck, and will actually, I think, inform some of WorkSafe BC's specific activities to produce additional resources and tools that are sector-specific.
Great, thank you. And Judith, can we come back to you, because I'm interested in knowing, like, how would another community get started on a place-based social pediatric model? And is it to have an application, do you think, in more rural, small communities?
Actually, I think it's a great model for a small community. I think the place-based concept is useful for helping people to identify what are their assets and resources. Certainly, myself and other members of our team would be happy to talk with people who think that they have some of the right elements. Basically, a general premise of this model has been pretty much all of the resources that we have drawn upon are resources that, to a large extent, already existed. So there were already nurse practitioners that had a mandate to provide primary care. There were already, within a health authority. There were already public health people who were trying to engage with folks and engage and do health promotion. So basically, the difference is that we brought people together to say, could we work differently to try and address these, this array of issues and deploy our resources more effectively. So I think, and then for us, the community, our community is now a very activated community. They're very, there's a lot of expertise in this neighborhood, but 10 years ago, 8 years ago when we started, there were pockets of that. That expertise wasn't all brought together in a way to develop a broader strategy and to work with us. So that being mindful of who you partner with and creating a base of support in that partnership, whether you're the community members who are looking for health partners or whether you're the health folks looking to partner with folks in the community. And certainly some people don't get it and they go on doing their own thing in their own sector, but other people say, wow, it makes my job so much easier if I can do what I'm good at, and I know I can count on other people to do what they're good at for this child and this family.
Great. Judith, just before we close, how could people get in touch with you? Can you just give us your email address?
So my email is judith.lynam, L-Y-N-A-M, @nursing.ubc.ca.
Great, and we'll put that on the website as well. Well, everyone, we're just about at the close, and so I would like to thank all of our panelists, Stephen and Judith and Iglika. Thank you for sharing your research and your knowledge and what you're doing, as the work that you're doing on an ongoing basis. It really is very inspirational. It's wonderful to see some of the new things that are happening. I'd like to thank everyone who's joined us today for your attention and thoughtfulness and your questions. We'll be following up with a short survey. I hope you'll respond, as it helps us to learn from these events what's working, what we can do better next time. And we'll also be continuing with our webinar series, so watch your inbox. Our next webinar will be on NGOs and local governments working together to build healthier communities. So we'll watch for that. And in the meantime, we hope that you enjoy the rest of your day and that you'll join us again. Thank you very much.
Thank you, Mary.